In first part of diuretics, we talked about the classifications of diuretics according to need in the renal and electrolyte block, and there I also mentioned some previous past year MCQ asked in KU BDS 2024 second year, and classification I mentioned in detail. Now I will be talking in detail about the mechanism of action, usage and adverse effect of these some of these important drugs. So hope you will go through the full lecture. Diuretics. Diuretics, first class we mentioned in previous lecture was that high ceiling diuretics. High ceiling diuretics. High ceiling diuretics, or also call it as loop diuretics. Loop diuretics. So in MCQs mainly or Viva, besides this first name, second name, mentioning second name, uh, teachers can ask the question that give the examples of loop diuretics, or which of the in MCQs which of the following is the example of loop diuretics. So for that at first we will see mechanism of action. For this mechanism of action, you should know the renal physiology at first. This renal physiology I will discussing in detail about the physiology subject, but here I just drew the basic structure of the nephron and glomerulus, so that it will be visible to relate the site where these drugs will act on. Yes, if you know the general anatomy about renal system, nephrons and glomeruli, you must be knowing that this is your afferent arteriole and this is your efferent arteriole. Again, though the picture is not so good, I just want to follow the normal anatomy, that you must be knowing that this afferent arteriole, its diameter is larger than the efferent arteriole. Why this is needed, I will explain in detail in renal physiology block. And this is nothing but tuft of capillaries, tuft of capillaries, you call it as glomeruli, glomeruli, multiple glomeruli, singular. If there is single, then it will be glomerulus. So this is just general English, nothing more than that. And this is will be your Bowman's capsule, Bowman's capsule, Bowman's capsule, and up to somewhere here. However, the picture is not so clear. Let's suppose this is initial or beginning part of the nephron, which you call it as proximal convoluted tubule. This will be descending limb loop of Henle, thin descending loop, descending limb loop of Henle, thin ascending limb loop of Henle, and this will be your thick ascending limb loop of Henle, tall up to here. This initial part is early distal convoluted tubule, and this will be your late DCT, and here will be cortical collecting tubule or duct, medullary collecting tubule or duct, and duct of Benelli at the end. So this is nephron, part of nephron, and this is glomerulus. So let's see where does this Haslin will act on. So this Haslin will act on lining cells of the thick ascending limb loop of Henle, thick ascending limb loop of Henle, and again if you know the anatomy or physiology, you must be knowing that here on these cells resides very important transporter you call as sodium potassium 2 chloride co-transporter in this luminal cell lining epithelium of the thick ascending limb loop of Henle. So I will enlarge this one cell here, and the reference for this pharmacology I am taking from the Essentials of Medical Pharmacology by K.D. Tripathi, 8th edition. You can follow that book for detail, and some other books also. Few points I am taking from some other books also. If there will be necessary, I will mention that book also. So don't worry. Here is the very important transporter. This is sodium chloride and potassium. By this transporter, two positive ions and two negative ions, that is sodium and potassium, are positive ions and chloride is negative ions, and equivalent, the ions will be transported in equivalent amount, so that there normally there will not be created, this is your lumen of the nephron, so that there will not be created any potential gradient between this luminal cell and lumen. normally, but this potential difference, this between them potential difference is created by something known as potassium leaky channel. Here will be your potassium leaky channel, and this will draw some of the potassium outside the this lining cell and into the luminal, into the lumen. And you can relate this, might, let's suppose this, so potassium may be transported outside, and again this potassium may circulate inside again. However, because this is transporting inside in equivalent amount positive and negative ions, due to leakage of these potassium ions, here will be created some positive potential. I will explain later. Just show here. I am not drawing normal physiology at first. And this is your basolateral membrane. Since this is at basal side and laterally, so basolateral membrane. And here will be very important transporter again, which is the feature of all cells. All cells have this transporter, what you call it as sodium chloride, sorry, sodium potassium ATPase, sodium potassium ATPase, that transports 2 sodium inside and 2 potassium inside and 3 sodium outside, outside. And here again will be potassium leaky channel on this basolateral membrane also, and this transports some of the potassium outside the cell, and this sodium, once transported inside, will be transported outside the cell and go into the extracellular fluid. This chloride will be transported again outside into the extracellular fluid, into the interstitial fluid at first, then extracellular fluid, that is plasma, by chloride transporter. This is chloride channel, this is potassium channel, and this is sodium potassium 2 chloride channels, and this is sodium potassium ATPase, So now this is normal physiology. Here sodium chloride and potassium is transported inside the cell in equivalent amount, and this sodium and chloride, since sodium and chloride is greater amount in the extracellular fluid, it must be transported outside the cell, interstitial fluid, then plasma. Same thing is happening here. And potassium, since potassium is in a higher concentration inside the cell, it must be retaining in the cell, besides leaking of some of the potassium ions also. Now what this high ceiling will do, take example of furosemide as prototype drug. What is prototype and prodrug? I mentioned in detail in the cholinergic drugs classification, so you can look there. Now this furosemide will act on this transporter and block this transporter protein, and it specifically bind on chloride binding site of this transporter protein, and this transporter will be inhibited. Again, I deviate from mechanism of action again towards normal physiology. Since hair is creating the positive potential in the lumen. Why? Because initially there is no potential difference between lumen and lining of the lumen epithelial initially, but due to leakage of this potassium, here will be created positive potential outside relatively and negative potential inside here, that is positive potential will be created in the lumen. This positive potential why needed? See here, since this positive potential is created here, there is in lumen there is also some bivalent metals that should be transported inside the cell and in the plasma. For example, magnesium, calcium, these are bivalent ions. Because of this positive potential and here also positive charged particle, they will try to they will repel each other, and this positive potential difference between between renal epithelial and this lumen body's physiology will try to neutralize this potential difference again. So to neutralize this potential difference again, these bivalent metals will be transported through paracellular pathway into the interstitium and then the plasma. Calcium. See, this leaking of the potassium is the important driving force to transport the magnesium and calcium into the plasma from the lumen. So this is normal physiology. Now what I am trying to say that from the definition of drug, what you know, that drug is any substance or product that is used or intended to be used to modify or explore the physiological systems or to change the pathological states. Following the definition, this drug what is doing? Blocking this transporter and disrupting the normal physiology, that is it modifying the normal physiology. And why I mention in detail the mechanism of action? Because any drugs that act on the host tissue, that is in what animal you use, in human or other animals, if the drugs act on the host tissue and modifying any physiology or exploring any physiology or changing the pathological state, what this will disrupting the normal physiology. And if you know this normal physiology, you can know the usage, what can be its usage or adverse effect or contraindication. From if you know the mechanism, you can remind it easily. For example, let us suppose take here example of acetylcholine. This acetylcholine is the main neurotransmitter at postganglionic parasympathetic fibers, and this will be mimicking the parasympathetic actions. So if you need the parasympathetic action, you will be giving drugs same as like acetylcholine, or if there is already enhanced or exaggerated function, you will be inhibiting this acetylcholine function. And if you inhibiting this acetylcholine function, if you know what it does, you can give in that case if there is required. And by inhibition of this acetylcholine, what clinical significance can occur, that will be your adverse effect. So what I am trying to mention, that if you know the mechanism of drugs that act on the host tissue, I am not talking about the antimicrobials. Antimicrobials will not act on the host cells, it will act on the agent that causes the disease, microbials. So adverse effect usage there will be different, but in these drugs that act on the human cell, human tissue, what it is doing, if you know that, you can know the its usage and adverse effect. See here, since this transporter transports these ions will create the hyperosmotic in medullary interstitium, and by this creation and maintenance, again there will be retention of the water, and excess loss of the fluid from the body will be prevented. That means if you need the prevention of these molecules, you should not inhibit this. But if there is already excess fluid by any other pathology, if you inhibit this transporter, there will be inhibition of the retention of electrolytes and fluids, and decrease the electrolyte and fluid volume inside the body, and maintain the desired action. So what will be its usage? Its usage will be, I will draw this figure. Usage of this high selling diuretics. Main use is in edema. It is excess accumulation of the fluid in the interstitial spaces, and by what mechanism this occur, I will explain in edema pathology. So just remember here, its usage will be in edema of any cause, that is, it might be irrespective of etiology, causating agent, causating factor, whichever is, you can apply these drugs. For example, the etiology might be cardiac, hepatic, or renal. Cardiac, hepatic, let's suppose there is congestive heart failure and heart is not pumping the effectively blood, so there will be accumulation of the plasma fluid or blood in the capacitance vessels, and due to the excess hydrostatic pressure, this that fluid, due to the accumulation, that fluid leak out the interstitium and cause the edema. Here also in hepatic cases, let's suppose here is cirrhosis. In cirrhosis, what will happen, the normal portal system will be inhibited, normal portal system will be inhibited, there will be portal hypertension, and due to that portal hypertension, again fluid from these portal vessels, it will increase the hydrostatic pressure, and there will be edema. In general, for example, let us suppose there is nephrotic syndrome. Nephrotic syndrome it is very interesting. I will be explaining in pathology that nephrotic syndrome, there is the loss of the disruption of the this glomerular transport mechanism, and Bowman's capsule, and there will be loss of the plasma proteins, electrolytes, fluid, all glucose, all will be losing due to increased diameter or charge disruption and and that will lead to the hypovolemia. And again, by physiology, tubules, nephrons will try to retain the salt and water, and that salt and water retained, but there will be deficiency of the osmotically active particle, mainly plasma proteins and glucose, and due to that there will be dilatation of the fluid, and excess hydrostatic pressure again will cause the edema. So I will talk in edema in detail in pathology. So here use is in edema. Edema again specify some uses like cerebral edema. Cerebral edema. Cerebral edema, this is very dangerous condition, but this hastening is not giving alone. It is combined with hastening. It is combined with osmotic diuretics like mannitol, osmotic diuretics, like mannitol to enhance their efficacy. Next will be sorry. Next will be acute pulmonary edema that may be precipitated by left ventricular acute left ventricular failure, followed by myocardial infarction. Next use we can give it in, let us suppose hypervolemia caused by blood transfusion. Hypervolemia, to reduce hypervolemia due to blood transfusion. Again, if there is transfusion of whole blood, there is fluid again, and this generally transported in the anemic patient, so there is need of the RBCs mainly, and there will be, since transfusion, there will be increased plasma volume. So to reduce plasma volume, this can be given there also. In that case also, if there is excess or more amount of transfusion is needed, then you can use it in, for example, hypercalcemia of malignancy. In adverse effect, I will talk about this. Here you are seeing, by this by virtue of this transporter, magnesium and calcium is also transported into the extracellular fluid, and if there is excess calcium or magnesium in the extracellular fluid, this should also be this transport should also be inhibited to maintain the normal calcium level in the blood. So if this transporter is blocked, transport of these ions will also be inhibited. So these drugs can also be used in hypercalcemia of malignancy. There are some many other uses also. You can follow the textbook. Again, from this mechanism of action, I will mention the adverse effect. Adverse effect. Since you are seeing here, there is inhibition of transport of sodium chloride and potassium, but mainly the potassium deficiency will occur. How? Since there is inhibition of this transporter, later on in distal tubule and in early distal tubule there is transporter of sodium and chloride, sodium chloride symporter, that will be inhibited by the thiazides, medium efficacy drugs. By that mechanism, because this transporter is not inhibiting that transporter, by that mechanism sodium and chloride will be retained later, and compensate some of the loss, but aldosterone, if you know the mechanism, aldosterone what will do it, it will finally transport the sodium, and along with sodium, water always flows the sodium, water will also be transported, and since sodium is transported inside, potassium, again to maintain electrical neutrality, positive ion should leak out, and there occurs leaking of the or transport of the secretion of the potassium ions, and there will be here is also occurring loss of potassium, and there will also be occur loss of potassium. So profound loss of potassium will occur, and how this occurs I will explain in mechanism of the thiazides and spironolactone. I will mention there. There will be main moral of the story is that if this transporter is inhibited, these ions, electrolytes will be deficient, and there will be major deficiency of the potassium will be hypokalemia. This is important, very important adverse effect, very important, and uh, sometimes it may be dangerous too if there is excess loss of the potassium, hypokalemia. And to counter this hypokalemia, there is formulating, like you can increase the excess potassium intake, increase potassium intake, or you can give the potassium substitute as potassium chloride substitute. This is not commonly given. And next you can simultaneously use the K plus sparing diuretics, that is K plus sparing diuretics, spironolactone, eplerenone, amiloride, triamterene, etc. K plus sparing diuretics you can use concurrently diuretics. This is major way to counter this hypokalemia. How this will do, I will explain in mechanism of action of this K plus sparing diuretics. Then there will be electrolyte imbalance, electrolyte imbalance, fluid and electrolyte imbalance. Why? Because this transporter is inhibiting many transport of many electrolytes and fluid. So there will be mainly deficiency of these electrolytes and fluid electrolyte imbalance. Next will be your dilutional hyponatremia, dilutional dilutional hyponatremia means loss of the deficiency of the natrium, that is sodium. This will be dilutional only, because I mentioned and will be mentioning in detail also later, that some of the sodium will be transported by other mechanisms in distal tubule and some other parts of the nephron. Then next will be your hypomagnesemia, hypomagnesemia and hypocalcemia, hypocalcemia. Why? If you know the normal mechanism, normal physiology, by virtue of this transporter, these bivalent ions are also being transported, and if this will be inhibited, this transport will also be inhibited. So there will occur hypomagnesemia and hypocalcemia. And very important adverse effect of this furosemide is autotoxicity, that is dose related hearing loss on if drug is used in prolonged period and or in high dose, there will loss of the hearing, dose related hearing loss. And this will occur mainly this furosemide and some other its congener like bumetanide and toracemide. This autotoxicity will be less severe than this furosemide, and this autotoxicity and nephrotoxicity is the important adverse effect of the aminoglycoside antibiotics. I will be talking in detail in antimicrobials also. Aminoglycoside antibiotics like gentamicin, tobramycin, kanamycin, amikacin, paromycin, etc. There are many examples. So this will be your important viva and MCQ question, and from that aminoglycoside also, that what is the which of the following is the nephrotoxic drug. It is asked in again I mentioned KU 2024 BDS second year BDS second year examination at Mando University. Ask what question was that which of the following is the nephrotoxic drug. There were many examples. There are four options. Among them, right options were gentamicin. Gentamicin is also aminoglycoside antibiotics, and all aminoglycoside antibiotics cause nephrotoxicity. So see how important these drugs, usage, adverse effect and contraindication, everything is important. Autotoxicity, dose related is hearing loss, and again there will be some other changes like hyperuricemia, 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 because this hyperuricemia how occur? Hyperuricemia, it is uric acid is secreted from the proximal convoluted tubule, and this drug by some mechanism will inhibit its secretion and facilitate and hyperuricemia and facilitates its reabsorption, and there will be hyperuricemia and hyperglycemia, again hyperglycemia hyperglycemia also, and there are many some other adverse effects also, like in GI, and CNS. In GI there will be occurring nausea, vomiting and diarrhea, major GI adverse effect, and in CNS it will causing the like giddiness, uh, and some other mental consequences will also occur by use of this high ceiling loop diuretics, high ceiling or loop diuretics. So, and adverse effect and usage almost will be uh, similar to this diuretics of uh, thiazides and thiazide like drugs also. I will mention in next part 3, and in part 3 I will also mention mechanism of action, usage, adverse effect of Kepler's sparing diuretics, and osmotic diuretics, stazolamide, that is carbonic anhydrase inhibitors, in next part. Hope you understand this and you enjoy the lecture. Thank you for watching.